Hello, and thank you for all coming, braving the stormy weather and making the journey here. It looks like we have a pretty full house. I think more people are going to come, so they'll probably come in the side door here, and hopefully they can squeeze into some seats and fill in around. So if there's some empty seats beside you, feel free to squeeze in so that latecomers can come in and sit by the aisle. Okay, so welcome to World Cancer Day, the public forum on how to survive cancer, not beyond us. It's the second annual event presented in collaboration with the Cedars Cancer Institute, Cedars Cancer Support, and the Goodman Cancer Research Center. My name is Dr. Luke McCaffrey. I'm an assistant professor in the Department of Oncology at McGill University. I'm also a member of the Goodman Cancer Research Center, GCRC. Dr. Morag Park couldn't make it tonight, so I'm filling in for her as moderator for tonight's session. And I'm also acting as representative here for the GCRC. Cancer is a devastating disease that affects millions of individuals and their families. So a fundamental understanding of the causes of cancer is essential to develop innovative ways to prevent, treat, and cure cancer. And so this can be achieved through a number of means, in particular through research, but also through education. So that's what brings us here tonight, is the education aspect, where we can learn, ways and strategies for living beyond cancer. The GCRC is a research center that's brought together numerous internationally renowned scientists to perform fundamental research into the understanding of cancer, cancer prevention, prognosis, and the treatment, with the collective aim of improving treatment and the overall management of cancer. We also aim to provide an internationally recognized training ground for future generations of cancer researchers. So tonight, we're collaborating with the Cedars Cancer Foundation, a hospital-based charity whose mission is to provide comprehensive cancer care to patients, and also to provide healthcare equipment and infrastructure for healthcare providers. In the end, to provide support for patients and their families. So there have been a number of initiatives. One is through Can Support, and there's a table outdoor, which is an initiative to provide support directly for the patients and their families. So the Cedars Cancer Foundation also supports cancer research, and so here we have a real connection with the GCRC. So we do receive funding from them for studentships and also through innovative research grants. So there's a real connection, and so bringing that here through these public lecture series, I think, is an obvious extension of those existing collaborations. So World Cancer Day is a worldwide event that's aimed to save millions of preventable deaths by raising awareness and education to stimulate discussion, but also to stimulate individuals to take action against cancer. So this year, World Cancer Declaration is on healthy choices that are not beyond us. So there are things that people can do to move beyond and live healthily beyond cancer. And so some of the themes that are important for this year are things like healthy living, early detection, treatment for all, and improved quality of life. So we've assembled a group of experts tonight that are going to touch on these areas of how to survive cancer, which is not beyond us. So we have Dr. Manuel Borod, who will be talking about cancer survivorship. Jordi Perez, who will be talking about cancer pain management. And Dr. Robert Kilgore will be discussing exercise and nutrition. So after the speakers, we're going to have a question and answer period. So I think each of you received a little card, so you can write your question on there, and then at the end of the talk, some volunteers will come around and collect those cards, and we'll read the questions. They can be in either English or French, so you can write it, and the response will be in the language of your choice. But there won't be a translation service provided. Okay, so I guess the first order of business is I'd like to introduce Gwen Nakos. She was treated with cancer at the RVH at the age of 38, and has since been a dedicated volunteer and a leader at the MUHC. So in 1988, she founded the Cedars Cancer Support, which offers psychosocial, practical, and educational financial support to cancer patients and their families. She's a member of the MUHC Board of Directors, chairing committees on quality of life and the Board of Communications Committee. She also serves on the Board of Directors for the Cedars Cancer Foundation and chairs the Cedars Cancer Foundation Dragon Boat Race and Festival team. She's previously served as the Board of Director for the Royal Victoria Hospital Foundation, and was president of the Cedars Cancer Institute.
Good evening, and thank you for making the effort to get here tonight. I'm sure that you're going to find the speaks very enlightening and invigorating. The purpose of my being here is really just to give the sense of history of why we're here today. It was 2.5 years ago, in August of 2012, the Union for International Cancer Control had their worldwide conference here in Montreal. And it was Rosalind Goodman who reached out to Jeff Shammy, who's the Director General of the Cedars Cancer Institute, and to me, and said, why don't we do something together? Why don't we do World Cancer Day, which every year is held on February the 4th, and it is an initiative of the UICC, the Union for International Cancer Control. So we held our first one on February the 4th, it'll always be on February the 4th, in 2013. And it is a joint venture between the Cedars Cancer Institute and Cancer Support and the Rosalind and Morris Goodman Cancer Research Center at McGill. And I wanted to pay special tribute to Rosalind Goodman because Rosalind Goodman succumbed to her cancer last year. But if it weren't for her and her initiative and her reaching across the divide to us, we would not be here tonight. So I wanted to pay special tribute to Rosalind, and her daughter Shauna is here tonight. And we really appreciate what your mother has done, and her legacy will live way, way on beyond her years. I want to thank Annette Novak from the Goodman Cancer Research Center, who is an unbelievable force, and Miguel Bernier Jr., who works with Cancer Support, and with Andrea and Robitaille for putting this evening together. Thank you, and I'm sure you'll enjoy it.
Thank you. So I think an appropriate way to start is to hear from hear a patient voice. So we have here with us tonight Tristan Williams, who's going to share his experience as a patient. So he's a 2-time cancer survivor, was diagnosed with multiple sclerosis as well in 2009. So at age 12, he was diagnosed with thyroid cancer, and after 2 successful surgeries and radioactive iodine treatment, he rejoiced with his family as his doctors told them that it was finally over. At age 19, his neurologist diagnosed him with multiple sclerosis, and then together with a nurse friend, he created the Road to UMS support group and the Tristan Williams Foundation to raise awareness and develop a sense of community amongst his peers. As he juggled both managing the disease and his personal endeavors, he was diagnosed with cancer for a second time. He underwent surgery to remove his right hip and replaced it with a titanium prosthesis to rid the cancer from his bone. Today, he's taking steps to empower himself as well as the people that surround him. He thrives on leading by example and uses his unique experience to inspire and to motivate not only himself, but his peers on a journey towards health and wellness. Tristan?
Hello? Yes, okay. Good evening. Good evening. My name is Tristan Williams, and I thank you for being here.
Do not wait for your life to be put at risk before you begin to open your eyes and start living. Do not wait for the perfect moment to arrive in order to create change in your life. The perfect moment is now. Right now is the perfect moment. I stand before you today with the highest intention to live and enjoy my life. I have faced circumstances that have tested my will to survive. At 24 years old, I could have never imagined that it would be where I am today. At 12 years old, I was diagnosed with thyroid cancer. At the age of 19, I was diagnosed with multiple sclerosis. And at the age of 21, I had my second battle with cancer. I have lived half of my life in fear of my death. Watching my family be heartbroken as they watched me undergo countless surgeries and treatments. I can remember my first round of radioactive iodine treatment when I was 12 years old. My body was emitting radiation, and in order to keep my family safe, they had to be kept at a distance. All they could do was look at me through this tiny little window from outside of my hospital room. I can never forget the pain I saw in their eyes as they couldn't hold my hand. They couldn't kiss me on my forehead to comfort me. You could say that I was a child living the life of an adult. I was engulfed by the fears and stresses that no child should ever have to bear. I was overwhelmed and traumatized by the lack of control that I had in my life. After completing treatment, I began to seek and find ways to begin to fill that void that I had in my soul. Around the age of 14, I began to sell drugs as a means to build my self-worth. Rebellion was pumping through my veins. I began to get in trouble. I was expelled from school. I had 6 weeks of boot camp to complete. I was lost and left delirious by the weight that cancer had left upon my shoulders. It wasn't until my diagnosis with multiple sclerosis in 2009, and my second diagnosis with cancer in 2012, that I truly began to change my perspective on my life. I became grateful just to be alive. You could even say the disease has saved my life. I came to the realization that I had to make a choice. Either I could continue to fall victim to my fears, my doubts, my jealousy, my thoughts, or I could choose to empower myself, seek support, education, honesty, and love, which is what I chose to. The challenges that we go through in our life can be overbearing, heartbreaking, life-changing. But these things do not have to define who you are or who you are going to be. Yes, living with cancer can be difficult. Living with cancer can be difficult. But with our life stories, we can inspire the minds of those who could lead us into the direction towards healing and one day find a cure for this disease. Cancer can be a nightmare, but has also brought all of us together today to share this moment and reflect. So together, let us fight not just for ourselves, but for all of those who may look to us for inspiration. Let us fight for family members, our friends, our loved ones, and all of the individuals that we have lost in the cancer community. They will never be forgotten. Let the impact that they have had upon our lives give us the fuel to keep pushing forward. All you can do is choose. Choose to fight for joy. Choose to fight for your voice to be heard. Choose to fight for support. Choose to see the beauty that you do have in your life. So today, what do you choose? What changes do you want to create in your life? What can you do today that can create a better tomorrow? So I will say it again. Do not wait for your life to be put at risk before you begin to open your eyes and start living. Do not wait for the perfect moment to arrive in order to create change in your life. The perfect moment is now. Right now is the perfect moment. And before I finish today, I would like to invite my good friend, Anand Jesse, to the stage. He's a motivational speaker, a lifestyle coach, a musician, and he himself is currently going through his own personal journey with cancer. So together, we're going to do an activity called the Hands for Hope. The Hands for Hope is everybody in this room putting their hands together to create energy for change. We're going to be playing our drums. All I ask is that you join us in your hands, join us with your heart, join us with your energy, and we will do the same. Before we get into the drums, I'd like to take a 30-second moment of silence. This World Cancer Day, let us reflect on our own lives. It's only 30 seconds. And if you could take 30 seconds just to think about your life and no one else's life, at this very moment, take these 30 seconds to think about you. So after the 30 seconds of moment of silence is done, you hear the drum begin to beat, and I ask that you join us. Thank you. Thank you. And happy World Cancer Day. Enjoy the rest of the forum. Thank you very much.
Thank you, Tristan, for your story and for that energy. I think it's a great way for us to start off. Really, that's what it's about, the energy of survival. So I'd like to introduce our speakers now. First I'll introduce Dr. Manuel Borod, who's then I think going to introduce the rest of the speakers in turn. So he's the director of the Division of Supportive and Palliative Care Programs at MUHC. He's an assistant professor in the Department of Oncology. He practiced family medicine for 20 years prior to embarking on a career in palliative care. He developed a home care program at Mount Sinai Hospital prior to coming to MUHC on a full-time basis. He's a particular interested in the role of humor in palliative care and has long been a dedicated teacher and mentor to medical students and residents. He's given many presentations at local, national, international conferences, and most recently chaired a session on the development of the MUHC Cancer Pain Program at the First World Congress here in Montreal last August. He's currently expanding the supportive care services of the MUHC, which includes the development of a survivorship program. So without further ado, Dr. Borod.
Got it. Well, thank you for having me. Thank you all for coming on a mild but somewhat snowy evening. I don't know who was here last year when we had our World Cancer Day. We talked about myths. The first myth I wanted to dispel is that the palliative care doctors don't get invited anywhere. So not only did I get invited last year, but I'm back. And I'd like to try to put into context some of the services that we offer. And rather than sitting down and then coming back and introducing everybody, I'll sort of introduce the other speakers as we go along, and I try to put it into context in terms of the services that we provide. We are part of the cancer care mission at the MUHC, and about 2 or 3 years ago, we changed our name from the Division of Palliative Care to the Division of Supportive and Palliative Care. And although the main focus of our activity had always been the palliative care unit at the Royal Victoria and then the Montreal General, you'll see shortly that our activities have changed quite a bit. You probably all know what palliative care is, and for that reason, often people really don't want to meet me, and I have to stand in the back of the elevator, and I have to turn my name tag backwards so people don't know what I do. But we look after patients whose illnesses aren't going to respond to curative treatment, and really paramount in the treatment is controlling pain and other symptoms that cause patients distress. But what's really changed over the last year is the fact that we no longer become involved only when patients are at the end of life. In fact, we're often involved very early in the course of a patient's illness, and as the illness progresses, there may be more palliative care services, but early in the course of the illness, we're providing many different supportive care services, and that's really what the focus of this evening is going to be. Supportive care, on the other hand, is really the provision of these services and services to people who are living with cancer, being treated for cancer, and really from the time of diagnosis through the various phases of their illness. We have a consult service within the MUHC, so it is currently at the Royal Victoria and the Montreal General in April, and by June all our services will be at the Glen site, so it's quite an interesting challenge for us to be providing all these consultation services at one site. And we have a number of outpatient programs. We have a palliative care day hospital for patients who have completed their cancer treatment and are no longer receiving curative treatments, but the focus is more on palliation. We have a cancer pain program, which I'll allude to in a moment. We have two unique and really autonomous programs providing psychological services and support to patients that you probably all know about, but I'll mention again in a moment. And we have a number of other services, and this is what happens when it changes the format. It's the cancer rehab program and the lymphedema program and the survivorship program. Some people ask me how we got from palliative care to survivorship. And I hope by the end of the presentation you'll have a better idea. Because really we're looking for patients who have completed treatment or patients who are living with cancer, and it could be from the time of diagnosis. So in our different programs, we have a cancer pain program, and we're supported, and many of the services, as you'll see, are supported by different foundations. The Louise and Alan Edwards Foundation supports our cancer pain program, as they do the chronic pain program. Shortly, Dr. Perez will be presenting, and I'll introduce him now so you'll see where he fits into our program. But Dr. Perez originally studied in Barcelona in Spain and came to do a pain fellowship here at McGill, returned to Spain, but we were able to recruit him to come back and be part not only of the Division of Anesthesiology, but really be the only physician at the MUHC who's jointly appointed to anesthesiology and palliative care. We together co-direct the Cancer Pain Clinic. It's a pleasure working with Dr. Perez because he is an interventionalist, and as an interventionalist, he likes to know where the needle goes. But since we've started working together, he is now really talking about patient distress and patient anxiety, and I'm asking where the needle goes. So things have changed quite a bit, but we're very fortunate to have him on our team. The Cedar Cancer Institute, soon to be known, and I don't think it's known yet as the Cancer Foundation, but I think is it now the Cedar Cancer Foundation? Because I wasn't sure on that. So they support our psychosocial oncology program, which provides psychological services to our patients, and of course Can Support, which was alluded to earlier, which provides a number of different services for psychological, educational, practical, and financial support. I got the four. I was worried about that. And finally, we have a number of different outpatient services. We have a cancer rehab program and a lymphedema program, which are together now at the Vendôme, 5252 Vendôme, hopefully to be expanded one day. It's supported by a number of different foundations. We're particularly grateful to the Quebec Breast Cancer Foundation, the RVH Foundation, the Cedars Cancer Institute, and the Rossi Cancer Network, which support various research projects there. And shortly, Dr. Kilger, who's a professor of exercise science at Concordia, will be talking to us. He is a co-director with Antonio Vigano, who's in the audience, of the McGill Nutritional and Performance Lab, and really experts in the area of exercise and diet and nutrition in the care of our patients with cancer. And finally, this all leads to the fact that we have a survivorship program. And really, when you look at what survivorship programs offer across North America, they basically offer many of the things that I'm talking about. They offer control of symptoms for patients who have completed treatment. They offer exercise programs for people who are living with fatigue and other symptoms. And we're fortunate to have Dr. Geneviève Chaput, who will actually be discussing with you in more detail some of the aspects of a survivorship program. Jen studied at the University of Montreal, but she did her fellowship in palliative care at the MUHC, When she started, I asked her if she would be interested in developing a survivorship program because Gwen and Jeff had dragged me out to Washington to look at some information about survivorship. And it seemed like a pretty good idea. I would never have imagined that Jen would have achieved in such a short period of time the successes that she's achieved in terms of developing various programs. And I will let her discuss that with you and present the programs that we are currently developing in survivorship, because she is actually the face of survivorship at the MUHC. So I'll welcome Jen to the podium, and I hope you enjoy your evening. Thank you.
Okay. So, I guess you guys know who I am. I'm Jen. I'm one of the doctors in the division, and I've been mandated to work really hard on survivorship for many of you who are cancer patients or cancer survivors, so welcome. And Tristan, that was beautiful. Thoroughly enjoyed. So, living with the history of cancer, what can we expect? Why are we talking about survivorship? This is an actual quote. After my last radiation treatment for breast cancer, I thought I would feel happy, but instead I was sobbing. I felt abandoned and terrified. This was the rocky beginning of cancer survivorship for me. We cannot reiterate more when a person finishes their treatment, how sometimes they feel at a loss of what to do next, because there was such a routine about the treatments, and now they're just navigating differently. So it's so important that we talk about it. Why else are we talking about it? Well, we're doing really great in the cancer field. We're having more patients becoming survivors because we have earlier detection, we have better treatments, and we also have an aging population. So there are more and more survivors. Right now, there's approximately 1 million cancer survivors in Canada, and by 2020, that number is expected to go to 2 million. So we better do something about survivorship like yesterday. Another reason we have to talk about survivorship is because I'm so happy when I hear that someone has gone through their cancer and they're a survivor and they've made it. We also know that when you have a cancer history and you have had certain treatments, you're at risk of developing other comorbidities, other problems with your health. So we need to monitor. And this is just a large study that was done, large cohort, tons of people, different universities, showing that if you're a cancer survivor, you're at risk of having maybe depression, maybe some cardiac problems on top in comparison to the general population. So we need to look after you guys a little bit more unique than just the general annual exam. Survivors have unique needs, yes. Many survivors are left with physical, psychosocial, and long-term effects of cancer and its treatments. I mean, actually, 50% of survivors have some problems. I mean, that's not insignificant. That's 1 in 2 people. These can be severe, they can be debilitating, and sometimes permanent. But we're working hard to make sure that they're the least possible and that we can help, even make them go away. What to expect after treatment? So I think that there's a whole bunch of education that needs to be done about expectations. And I think if we just spend time to educate on what is the norm, what can be expected or not, I think that really helps survivors just feel like, oh, I'm not, this isn't abnormal, really, this is part of my journey. So the desire to return to normal may be different, referred as the new normal. We might not be able to go run 2 marathons a year, but we're still a whole person. Each individual is different. It may take weeks or months to recover. For some people, it's a lifelong process. It's a lifelong battle. We need to adjust survivorship care according to each person. So long-term effects, all the jargon, the medical stuff, long-term effects, symptoms that persist after the treatment ends, and the late effects are symptoms that may not occur until late after life. And those are things like, being more at risk of having heart problems because you've had radiation in this area, for example, or because you've had a certain type of chemo. Can you think of issues or concerns that cancer survivors may face? If there wasn't so many people of you, this would be an open discussion, but I'm just going to go ahead with it. So actually, the 8 common issues of cancer survivors are psychosocial problems related to anxiety and depression, and especially fear of recurrence. There's cognitive deficit issues, people who go through something that we call chemo brain. Pain is a big problem. Female and male sexual dysfunction, which is such a taboo, and people don't talk about it enough, and we need to start talking about it more. Fatigue, sleep disorders, immunizations and preventions of infections, and survivorship is a very new field, and so even that point needs to be worked on. We're still trying to figure it all out. And a healthy lifestyle and exercise promotion. So I just want to go briefly to each one of them. So, psychosocial late effects. I don't think you ever forget the fact that it could come back. Does that ring for any of you in here? Cancer survivors report both more psychological distress and the use of mental services way more than the general population. Triple the risk of depression within 2 years of diagnosis. That is not insignificant numbers. 70% report high levels of fear of recurrence. That's more than, that's the majority of people. And because of that, what we worry is that there's actually an avoidance sometimes of surveillance. We're so worried that we're going to go for a follow-up, and it is actually going to be, maybe my test will be positive this time, but sometimes appointments are actually missed. And we know that particularly of the young adult survivors. So we need to work hard at making sure that prevention and follow-up is still being done. This is one that always disturbs me, the incidence of completed suicide among patients with cancer and survivors, approximately twice the general population. There's definitely an issue here with people feeling isolated and not talking out about this. There's points of increased vulnerability in the cancer continuum. End of treatment, you might have more of those psychological distress, anxiety, fear of recurrence at different time points in your life. So it's very important that we are aware of these specific points so that we can monitor appropriately. Recognizing depression. The #1 class of medication prescribed in Canada is antidepressants and anxiolytics. It must be out there somewhere, not just in cancers. #2 is cardiovascular disease medications. So it's important to recognize it, whether it's in yourself or a loved one, feeling depressed, having loss of interest for usual things, changes in your appetite or your mood, and in your weight gain, If you're having problems with your sleep, changes in your sleep. So all of those things are very important, because if you're going through this, we should be helping you and you should be reaching out as well. Coping, what is available to me? Well, it is treatable. There's counseling that can be done. There's also medication that can be given. We can get some support, reach out to the community, reach out to wonderful organizations like Can Support that have support groups, that have all kinds of possible things to make you feel that you're not alone through this journey. And the exercise, which I won't get into because I'm not the expert, we have a panel, but the evidence is impressive in terms of helping with overall mood. Cognitive deficits. Not being able to concentrate the way I used to has been the hardest for me. I'm hoping it doesn't affect my work. Well, it does. If you're a lawyer, if you are a cop, whatever you do, if you've gone through treatments, your brain might not be functioning the same way. And it's one thing to survive the cancer, but now you have to readjust as to how you live your life, and that might actually change what kind of job you do and what kind of functioning you have on a day-to-day basis. Brain. So that's what it is. Cognitive dysfunction that's most commonly connected with chemotherapy. There's a 40% increase in the likelihood that you're going to report that if you've actually had chemotherapy. So, executive function, learning, memory, attention, processing speed. Usually it goes away with time, thankfully. It can last up to a year, but for some people, unfortunately, it lasts for much longer. So are you affected? Are you someone that's been going through that? Do you frequently leave tasks incomplete? Unless you really don't like those tasks, that's another story. Difficulty finding words, turning left across traffic, that's hard for you. Little things like that. So, I'm not saying that we're going to be able to change it all, but just to be aware that that might be something that happens and is normal, and that, there's support groups in order to just manage it. That's already like half of the battle. Pain. Again, we have Dr. Perez who's going to be talking on the board, so I'm not going to say too much about pain, but that's also very important because it really affects quality of life. More than 40% of post-treatment cancer survivors experience chronic pain. Honestly, that's a huge number again, and I can't imagine having survived my cancer, wanting to get on with my life, but then on top of it, I just can't really function because I'm dealing with these pain issues. For some people, it's debilitating, and it's really important that we do things, which Dr. Perez will talk about. Things that you can do, though, please, please, please seek out if there's some psychological distress, because it has been shown to really decrease your levels of pain if your mind is in a good spot, you know. And, you know, acupuncture, there's emerging evidence for acupuncture, for yoga, for the whole exercise and well-being. And then there's the different clinics that we provide in our division. Male and female sexual issues. Well, cancer can affect your sex life. I mean, if you've had pelvic radiation, the anatomy might not be the same, so it's kind of like a problem. And how do we discuss that, and how do we manage that? Because it is definitely an issue. There's obstacles to what can happen, you know, feeling more tired, lost some self-confidence. You know, if you've had a surgery and you've had your breast removed, well, that might affect your self-esteem. So, I mean, these are all very important things that are part of, like, being a survivor that we need to address. So, you know, try to open up to your partner, talk about it, get some support. You know, there are some resources out there. The literature is showing that physicians, which is us, you know, can't blame everybody, but physicians don't ask because they're worried about, you know, embarrassing the person's sex life. But at the same time, when we do ask, people feel relieved. So, you know, speak up. There's resources to help you. Fatigue and sleep disorders. Another quote. I thought I could get right back into my normal work routine, but I'm finding that I just don't have the same energy that I used to. Well, that's another biggie. This is a large study that was done. I'm just trying to get buy-in. I don't want to get all medical on you guys, but you know, it shows that 80% of individuals who've received chemotherapy and radiotherapy do experience some problems related to fatigue. And in the people that have sleep disorders, you know, there's also issues of fatigue, anxiety, and depression, so it kind of becomes a vicious cycle. So it's so important to target all of those survivor issues. So why am I so tired? You know, first of all, there might be the normal tired for you, which is mild to moderate levels of fatigue that can persist 6 to 12 months after therapy without any other symptoms present. So you're allowed to relax on the couch. Maybe you need to have some activities that are less energetic for a while after your treatments. But if you have worsening fatigue, if there's new symptoms that are arising, of course we need to be aware. You yourself as an advocate, but also us when we come and see us in the office, because we need to think about doing further workup. Sleep hygiene tips. I mean, these are pretty basic things that you can do and empower yourself. You know, I don't know that I'm capable of doing any of them. Manage stress, yes. But things that you can do, that not everything is related to how the medical care gives you something. You know, there are things that you can do on your own to improve your quality of your life. Oh, this is the big dinosaur that nobody likes in survivorship right now, including me. Immunization and prevention of infections. We do know that survivors are at increased risk of infection and complications from vaccine-preventable diseases such as the flu. And we're talking people who have survived and people who are not immunocompromised or going through active chemo treatments. So that's kind of important to know. We know that the vaccines are best if given 2 weeks prior to the initiation of cancer treatment or 3 months after. And obviously, live vaccines are contraindicated if someone is immunosuppressed. Healthy lifestyle and exercise promotion. Again, not the expert. Dr. Kilgore is going to convince you guys of that on the panel tonight. But I just want to say strong benefits of physical activity. Unbelievable, the studies everywhere where I travel that show that physical activity can improve your fatigue, it can improve your mood. Really, overall quality of life is increased in patients who do regular exercise. And we're not talking, you know, oh my gosh, I've got to go to the gym every day. Just 30-minute activity 3 times a week, like going for a walk with your dog if you have one, or your wife if you have one. Another thing, it's not just quality of life, associated with a reduction in the risk of recurrence of cancer, and it increases the survival rate. So I don't know, I'm not that good with PowerPoint, but those 2 points should be like flashing. Smoking and cancer, not a good combo. I am amazed at 50 to 20% of all cancer survivors still smoke. Holy smokers. We got to do something about this. So we need to give you support in terms of smoking cessation because it can reduce your treatment effectiveness, worsen the side effects when you're going through the treatments, and, can make your surgery complicated by poor wound healing, and obviously it increases the risk of second cancer. So let's beat that battle and let's stop smoking and let's get you the support. And there is a program here, so we just need to direct you to the right thing. Coordination of care. Whew. I went to radiation treatment every day and the staff became like part of my family. Then when I finished, there was this instant separation and I felt at a loss. Yeah, that's a big deal. Be your own advocate. Be your own advocate. Know what you need. Ask for stuff. You might feel well, you may have survived, and we're so happy that you have. Honestly, it's always a victory when we get through the journey of cancer. But at the end of the day, even if you're well, we want to see you. Specialists want to see you. They want to monitor to see how you're doing. And your family doctor wants to see you too, because they want to check the blood pressure and they want to check a whole bunch of things that could happen that don't cause you any symptoms in the short term. So, help us help you. So working with your oncologist and your primary care physician, go to your annual exam. Do it. I don't like to do it, but I do it because I have to. Assessment of late and long-term effects of the treatment. Yeah, your primary care doctor can do that. They're the ones that are the expert in lipid profiles and see if you're going to develop diabetes or if you're going to develop hypertension, and they know how to manage those things. So they need to be involved in your care. And your oncologist and your radio-oncologist, of course, they need to be involved to make sure that, there's no recurrences of your cancer, too. So you still need to see us after you survive. Damn. Don't know why this was gone. I don't know. Please remember, we need you to help us take care of you. We really do. Always call your doctor, call your IPO nurse, call the social worker, whoever you're connected with that's helping you with regards to what you're going through. And really, the kiosk in the front that give you more information about everything, please visit them as well, because it's unbelievable the resources and the work that everybody does here with the Rosalind Cancer Network, and Cancer Support. There are a lot of things that are helpful in the journey. Thank you. A special thanks to all the people that help put all this work together.
I would like to start thanking the organizing committee and the audience for allowing me to be here in front of you and present this data. I will summarize my presentation in 5 points. I will be talking a bit about the scope of the problem, how big the problem we have now in terms of cancer pain, the consequences of cancer pain in the individual, the current treatment that we can offer, or that is being offered to cancer patients, and the newer initiatives. And in particular, I will be presenting our cancer pain clinic initiative at the McGill University, and maybe just a bit about future cancer pain management. So how big is this problem? We know that cancer is big, and just talking about Anglo-Saxon countries, we know that the incidence of cancer among the population is quite high. Maybe Canada is not the highest, as we can see, but it still is high. And as a curiosity, I just put the one that had the highest incidence, which is France, and the one with the lowest incidence among the countries that can provide good data, and that it's Oman. So, but still, it's a pretty high prevalence for a very common disease. What about mortality? We know that, unfortunately, in Canada, almost 1/3 of deaths are caused by cancer. And obviously that means that this is a very, very important problem. What about cancer pain? When cancer pain is observed? Are diagnosed almost in 50% of cases. During the treatment, it's more prevalent. prevalent is almost 60%. It's even more prevalent, it's even more present during advanced stages. But in my opinion, what is worse is when you see a patient who does not have a cancer anymore, is cancer-free, and is still suffering with pain. That it's seen up to 33% of cases, was presented up to 40% of cases. So overall, 50% of cancer patients, they suffer with cancer. That to me is a tragedy. But why do we feel pain? Is it good to feel pain? So I have to say that yes, being a pain specialist, I must say that it's a blessing that we all have pain. Because the hockey player will hurt himself more if he doesn't stop after feeling the pain. If we hold a very hot cup of coffee and we don't feel the pain, probably we will harm ourselves. So pain is a blessing in the sense of protecting us against nasty environment. So pain is taking us to the emergency, pain is asking us to stop doing something that possibly is going to harm us more. So pain is good. I will deny that I said that, but pain is good. In fact, pain is one of the signs that might be taking us to the doctor and possibly helping us identifying a cancer. So pain is among one of the 5 possible signs or symptoms that can help us identify pain. So pain is good, but it's only good at diagnosis, I would say, if any. So yes, this pain allows me to identify a problem that possibly was diagnosed with cancer. But why patients are having pain during the treatment? The diagnosis is made. What's the purpose of that pain? Why that pain is telling us that there's something is not going well, something is wrong? We know that already. So, even more, why patients are having pain during the advanced stages? Why this pain is really telling us something useful? It's not useful. It's just destroying our life. Even harder to imagine why someone who is cancer-free is suffering with pain. This is hard to understand because pain destroys us all. It destroys our physical life. When you are in pain, you don't want to move. When you don't move, you might build blood clots. You might die from that. When you don't move, you breathe less efficiently. You might have respiratory infections. But also when you don't move, when you are in pain, when your inner life can be deeply affected. In the audience, some people they might be pain patients, and you understand that when you are in pain all the time, your inner life, your mood is totally destroyed. But also affects our social life. You don't want to go out. You don't want to have fun. You don't want to be a person when you're in pain. It also affects our economy. Because, of course, treatments for cancer, they are very costly, and when you cannot work, of course, that has a huge impact on your economy. So pain is bad. But not only is bad for the person, but also actually it has been proved that having pain or relieving pain effectively can prolong life. This is a piece of a study that showed that patients receiving a certain treatment, they were living longer than patients receiving other treatment, which is also a good treatment for cancer pain. So which means that if we can control pain better, we might prolong the life of our patients. So let me just go to the next point, which is cancer treatment. There are numerous protocols, guidelines, books to help us clinicians managing pain better. So we know well the theory, but still with the best treatment, we cannot achieve a full pain control in all of our patients, unfortunately. The WHO, the World Health Organization, suggested a stepwise approach to treat cancer pain. And what they suggested in the 80s is that for a mild pain, you should use mild analgesics. If the pain is not totally well relieved with this first step, you should go to the next and then to the next. With these 3 steps, science says that 70 to 90% of your cancer cases or cancer pain cases will be more or less well managed. Unfortunately, this is not true, and this is based on the utilization of a drug that is morphine or opioids. And we know that morphine is very good, but also we don't like morphine and we don't like opioids. Why opioids and morphine is good? Because it provides good pain relief. Because it's very simple. It can be taken orally, it can be a patch. It's very simple to administer it. And it's very cheap. But unfortunately, morphine and opioids in general, they come with severe side effects. Sometimes this type of treatments, they have been associated with tumor progression because unfortunately they affect our immune system. And that can promote tumor progression, which means that we cannot fight the cancer as effectively as we should. And also, opioids, they have a poor reputation. When you put someone on opioids, whether it's for cancer pain or for non-cancer pain, the patient, they will ask you, is it that bad? You're putting me on morphine, so it must be that bad. And when the patient is presented with a cancer pain and you start opioids for the first time, they smell that something is going very, very bad. So to a certain extent, there's a very poor reputation, which is a barrier that we have to fight, a barrier that we have to overcome. These are some barriers that we have to fight as a clinicians. Barriers related to healthcare professionals. And in my opinion, these are the worst ones, because we as a clinicians, we should never have this type of barriers. Certain clinicians, they don't know how to manage pain. They don't know how to assess pain. If I ask you, what is pain? How bad is your pain? Describe your pain. Imagine describing an odor. It's so hard. For us, we have to read between lines when you express your symptoms. Unfortunately, clinicians, some clinicians, they haven't had the proper training. Therefore, pain becomes a very hard symptom to manage. There's also concern about substance. Because some substance, of course, they are controlled substance, and it makes your life a bit difficult when you start prescribing opioids to someone, because you have to just have certain control. Also, you are afraid of your patient becoming addicted, and you have to fight that fear. This surgeon that I spoke to said to the patient, it's been 2 years after I operated you. It's been 2 years since I removed your cancer from your lung. You should not be on morphine. And the patient started crying. And the patient is from up north. It's an Inuit, and I learned that these guys, they don't cry that easily. And he was feeling guilty. And then I spoke to the surgeon and I said, I understand your concerns, but you're not the first doctor that I speak to that suffers with a case of opiophobia. And he didn't say anything, but the message that I wanted to send is, I understand that you are afraid of providing narcotics to your patients, but if it's really needed, it's must. And if it's not you, somebody else should do it. And of course, certain medications, they come with severe side effects, and unfortunately, not all clinicians, they know how to manage these side effects. Unfortunately, also, the barriers, they relate to the patient. Some patients, they don't want to report pain. They are very stoic. Some other patients, they don't want to distract us from the true treatment, which is the underlying disease. Some other patients, they don't want to report pain because they might feel that by reporting that, it means that the cancer is growing. Or some others, they don't want the medication. They want to feel the pain. So it means that when the pain is there, maybe there's a recurrence, and they want to see the treatment given right away. Some other patients, they don't know, of course, because you haven't been trained, how to manage pain in general. They don't want to be a bad patient. They want to be a good patient. They don't want to bother us. And they are reluctant to take medications. Because when you take a medication, that means that you are sick. And we don't want to be sick. You are, as a patient, you are afraid of becoming addicted. It means that your pain will be better controlled, but then you will be hooked to a medication. To fight this, I always say that diabetics are addicted to insulin. They cannot live without it. That doesn't mean that they are addicted. It's just that they need a medication to control a symptom, and that's it. Of course, some patients, they are afraid of side effects, and that's a conversation that we need to have in terms of convincing them that all medication, all procedures, they come with side effects, but we have to be able to manage properly. And unfortunately, some medications, they are expensive, and some patients, they cannot afford to pay. And problems with healthcare, mostly because we have to raise awareness on cancer pain treatment among among the authorities. Some medications, some treatments, they are not reimbursed. Sometimes the most appropriate one is not reimbursed. And some countries, they have a very strict regulation as per controlled substances. And I'm going to give you a very clear example. One of the medications that we use quite frequently at the cancer pain clinic is a narcotic, and it's called methadone. I know that methadone has a very poor reputation, bad reputation, because it's being used for drug addicts. But methadone was used before drug addiction for pain. In France, you cannot have access to methadone for pain management. It's forbidden. If that is true, it means that the local health authorities, they are putting barriers to us to control well pain. So let me talk a bit about new initiatives. The Cancer Pain Clinic is an initiative that has put together what I think is a wonderful team of clinicians to treat pain effectively. So the clinical activities of the Cancer Pain Clinic consist of 3 ambulatory clinics a week. And we have a full-time access to a nurse who is a specialist in oncology and palliative care. And to me, the most important aspect of having a nurse that is so dedicated to this program is that can answer to the needs of our patients. Imagine the relief that our patients show when you say to them, if you have any issue with your cancer medication, with your pain medication, or with your pain, you call us. And within 24 hours, you will receive a phone call back just to help you manage your pain better. We don't have the data, but we are convinced that since the cancer pain clinics start working, the number of patients presenting to ER with pain crisis has diminished dramatically. From the cancer pain, we have access to an operating room to do procedures. As Dr. Borod said, I am an anesthetist and I like playing with needles. I can put a needle in certain places and I can try to kill a nerve, anesthetize a nerve, maybe put some, if you have a bone metastasis, I can try to put a bit of cement inside the bone metastasis, so hopefully the pain will cause less pain. The cancer will cause less pain. Also, we work with radiation oncologists. Once a week, the radiation oncologist helping us controlling our cancer pain better. And we have very rapid access to physiotherapists, to occupational therapists, and also to psychosocial oncology. And our customers primarily are the oncologists and palliative care doctors at the Montreal General Hospital, but also our mandate is to provide services to the whole McGill University Health Center, but also to the island of Montreal and to the province of Quebec. So we are a pretty busy clinic in terms of customers. Also, our activities are not only clinical activities. We teach. We love teaching. And we teach undergraduates to make them aware how important it is to treat effectively cancer pain. And also to postgraduates, to residents in different disciplines, to teach them the same, how important. In fact, we're very proud to have probably one of the fewest, if any, cancer pain fellowships to be offered, and hopefully we will start next year or the coming years, to specifically train doctors in the management of cancer pain. And our research activities, we want to promote our treatment by collecting data. And we recently conducted a retrospective study that showed that with our treatment, more than half of our patients experience within 2 or 3 visits very significant pain relief. In fact, this significant pain relief came with less medication taken. So we were not offering just medication for these patients. By combining our efforts in terms of the nursing techniques, the palliative care approach, the anesthetist approach, the radiation oncology approach, we could control better the pain, and patients, they were taking less medication in terms of opioids. These results, they have been published in 2 well-reputed conferences, and also our clinic will be hosting a special symposium of innovative cancer measures, cancer pain measures in this year at the Canadian Pain Society. So, what's the future? I think that the future is less cancer. And by controlling factors like tobacco, like overweight, like bad diets, probably we will see less cancer. Also, the future is better drugs or better treatments against cancer. In particular, targeted treatments. So we will be seeing now how for every single patient there's a single treatment that needs to be offered, that is personalized, that is tailored. I believe that the future is maximize effectiveness by minimizing side effects. And I think that one day, as it happened with HIV and AIDS, one day cancer will be considered a chronic condition and no longer will be a lethal condition. And I really hope that we might see that with our own eyes. So we're looking for the golden pill. The golden pill or the golden treatment. The one that it's effective, it relieves pain, that it's safe, it doesn't come with any side effects whatsoever, that is very convenient, you don't even have to take anything, you don't have to remember to take twice a day, and that is very cheap. So the day we discover that treatment, certainly we'll get the Nobel Prize and we'll be extremely rich. And with that, I finish my presentation. Thank you very much.
Slideshow?
That one.
I'm not going to give his presentation again.
So just get out of there. Go back to the PowerPoint down here. Just click on that, and then click on your presentation. There you go. And F5.
I'm so fortunate to have a number of children in my presence tonight to help me with my PowerPoint presentation. Well, before I get started, I would really like to thank the organizers of tonight. I know that Andriane has worked extremely hard to organize this, and I know that Miguel has worked equally as hard, and I know that Annette, I keep on meeting Annette every now and then at these conferences, and I know that behind-the-scenes people like Jeff have been working very hard with cancer support. So I thank you very much, and I thank Annette I thank Andriane for inviting me because it gives me the opportunity to wear my Christmas tie that my kids gave me that I don't wear all that often because I'm not a tie wearer, so I'm going to make sure that it's really well pronounced. Okay. I have been asked to speak on two issues that have been close to me for the last 30 years. I've been an academic for the last 30 years, so if my slides happen to be a little bit more academically slanted than entertaining, I know that I have some of my students in the audience now, so I'm going to check to make sure that if they're awake, then I'm doing okay. If they're asleep, I'm doing okay. All right, so the title was kind of, when I looked at this title and Andriane said, we want a kind of a title that's going to be catchy. And so she recommended that the proof is in the pudding. I said, Andriane, what does that mean? And I know that several of my colleagues said the same thing. What does that mean? So I had to look up the meaning. So the proof of the pudding is in the eating. This was actually in an Old English proverb. An Old English proverb back around 1600, where they used this term. The proof of the pudding is in the eating. And I really liked that when I saw that, because as a scientist, it's almost let me think that I'm hypothesis testing. you know, here with the pudding, and the proof is actually when you eat it. And then I said, puddings. Who actually has to eat a pudding to say that it's good? So I put just some of the myriad of puddings that are up there. And so to say that, you know, the proof is in the pudding, you've got to taste something before you can actually say that there's good quality to it. And so that's going to be the theme behind my talk with you tonight. So when I talk about nutrition and I talk about exercise, you've got to start to do it to say that it's in the pudding. Okay. And I know that I would probably want to put a little bit of Tristan in each one of these puddings so that, you know, when that happens, people can really get the full benefit of it. Okay, so my presentation outline. I've actually got two sets of presentations in one. I'm going to be talking about some of the top 6 nutritional recommendations. And I'm taking a bit of a different slant tonight, rather than talking about what is the newest supplement on the market, or what is the, you know, is seaweed better than kelp? Because these types of things have been, you know, a little bit off the wall and can keep us here for hours and hours and hours. But I'm going to, I took the approach of listening and reading and thinking about what some of our clinical nutritionists and clinical dietitians say right on the floor. What do they say to their patients when they see them? Now, I'm not going to be putting you to sleep, I hope, because a lot of this stuff may not be as exciting as is kelp or seaweed. But I think that you'll see some very interesting recommendations come through. And if you listen to them and you read them, that they are kind of the backbone and the framework of what good standard nutrition is. And I don't think it's going to be a surprise to anyone sitting here tonight. First recommendation, maintain a healthy weight. Well, that seems like a big no-brainer. And when it comes down to, by the way, Tristan, I put you in some of my puddings, so I wasn't too sure. I knew you, I kind of looked around to see where you were, but you're in my pudding now. Okay. Maintain a healthy weight. Strong predictor of morbidity and mortality during cancer treatment is weight loss, and you have to be hidden under a rock for a long time not to get that. It's one of the standard things that we see. And in general, people who lose weight do worse than those either who maintain it or who increase weight. So that's pretty sound advice, not surprising advice. It's the maintenance of the weight, it's the prevention of the weight loss that is the difficult thing to do. Again, maintaining a healthy weight, there is lots of evidence in various cancer types, and there's a multitude of literature, especially with breast cancer, that weight gain during treatment will actually worsen survival and increase the risk of reoccurrence. This can be seen 5 and 10 years down the road when the reoccurrence comes back, and when it comes back in a worse state than they were before because they have gained some weight. And so obesity is going to be a comorbidity and very high risk factor when it comes down to cancer treatment and beyond. So really, what is the key message to all of this? The key message is for people who are normal weight, great, and those that are underweight, try to gain some of that weight. And for those who are overweight or obese, especially during treatment, try to maintain and focus on weight loss after the intensive treatment is over, because I would feel that there's a lot of things going on. As Dr. Chaput has mentioned, as Jordi has mentioned, lots of things are going on. You don't want to start a weight reduction program probably in the middle of your chemotherapy and your radiation therapy. You have some other far more important things to think about. Once that is over, the recommendation would be, so that recurrence is going to diminish, to start losing the weight. So there are really no clear guidelines to any of this as a control. Another recommendation that has come out from the floor is, again, just eat. You know, that seems easy to say, but sometimes for some of us, and some of you, it's sometimes in your treatment, very difficult to do. But if people are eating what they want and managing to maintain their weight, that's great. And so if that's working, you know, you don't have to fix anything, because nothing seems to be broken. And so the clinicians are saying, we can't stress this enough. So don't start changing things now. It's not bothering you, but you don't see significant weight loss. So people tend to cling to the new things in the news, or the next miracle product. And for those of you who were thinking that I was going to talk about some miracle product or some very new things that are coming out on the market now in nutrition, sorry to disappoint you. Okay, but this is a big, big topic of conversation. No doubt on the floor, on the clinical floor, questions are being probably brought forward to the clinical nutritionists all the time with that. And I'm glad to hear that our clinical nutritionists want to bring people back to the basics. Okay? It's nice to read and nice to think about, but let's not go out too far. Okay? Quite often, due to the encouragement of family members or friends, the patient will have gone through some radical diet changes only to be eating less, be unhappy, and lose weight. I want to make a qualifying statement here. This is not a statement in disparaging the family or your friends, because your family and friends are trying to do the very best for you. Okay? And sometimes what they think is the very best could be the very worst. All right? So let's get that straight. They're helping out, but you are the controllers. You are the controllers of what you're going to be doing. So, trying to take control. At least that's why. Eat for your symptoms. Kind of a catchy phrase. Eating during cancer treatment is tough, more tough for others, and patients differ so much in so many different ways. Different cancers cause us to eat differently, want to eat differently. The side effects, the symptoms, things like that can really significantly affect the individual. So patients must try to manage symptoms as they arise. And there's a very good cancer guide that you're probably all aware of that I put down right on the bottom there in terms of the main page with cancer.ca. It gives a very, very good and simple overview of eating for symptoms and symptomology. Once again, eating for your symptoms, patients will be experiencing many different symptoms all at the same time, and they'll likely need to adapt their diet to very specific situations. And sometimes that's confusing, and you never really know what to do with that. And so I know I take the safe road, and I know the clinical team takes the safe road by saying, if things are getting a little bit too much for you to handle and your understanding of things is starting to get confusing, clearly we have this team of very strong professional people to go back to and seek their advice, because they can give you an individualized program with nutrition and other things. I'm just checking to see if the students are still awake. They're still awake. That's fine. That's good. See, my nutrition talks are usually more exotic than this, but when I said that this is some of the key issues, I find that these key issues are great, and it's easy for us to all understand. Another key issue, drink water. Okay? Again, another, what my daughter would say, no-brainer. No-brainer. Staying hydrated is probably at least as important, or even more so, than eating. Okay? Especially during some very strange and very difficult perturbations with your homeostasis, with your normal level of activity. Surgery and chemotherapy and radiation therapy can do some pretty interesting things to your body that can possibly significantly dehydrate you. And when you're dehydrated, many of your cells are dehydrated. And if you know, all of your cells need to have water in it in order to metabolize the foods that you're supposed to be eating. And if you haven't got water there, metabolism goes down, and therefore you start feeling the way you're feeling. So please, one caveat is, drink water as much as you can. The most important beverage is always water, but if you're a coffee drinker, coffee's fine. It's a fluid. Tea, soup, juice. Gatorade. Those of you, I think you all know what Gatorade is. Gatorade is also recommended for those people who are having a hard enough time drinking and keeping it in, okay, because it does contain, not only does it contain the fluids, it does contain some of the electrolytes and particles that you need in order to make cells function properly. Sugar. Yeah, increased sugar consumption has been linked, as you know, to obesity, heart disease, and probably no surprise, to cancer. And unfortunately, we all seem to abuse sugar. High sugar consumption has been linked to mortality and cancer recurrence. And this is with some very strong evidence in the area of breast cancer especially. So in terms of more sugar, people are losing weight, and the only way they can keep it up, by having, let's say, some interesting breakfast choices. And with that interesting breakfast choice, you can add a little something on top of your interesting breakfast choice. By all means, go ahead and do it. You can see what the primary purpose of this is, that you want to maintain maintain calories. Because your body consumes calories, you have to expend calories during the course of the day, no matter what you do. As you are all sitting here, in various forms of movement, either feet are moving, eyes are moving, mouth is moving, smiling, or something of that nature, you're consuming a certain amount of calories, so you need to have it. So without it, all of a sudden you find yourself becoming more fatigued, you become more lethargic, you start doing a lot of nothing, you become more sedentary, deconditioned, and then there's this downward spiral following that, so that you become a terrible patient for our physicians to work with. Eating when you have cancer. Clearly a healthy diet for a patient with cancer is similar to the diets that we recommend people to prevent cancer. That should be no surprise. Okay. And here's another no surprise. Rich in fruits and vegetables, whole grains, limited red or processed meats. Okay. Emphasis on white meat, poultry, fish, and seafood. This is somewhat synonymous to this Mediterranean diet that we've been hearing about all the time. Okay, so this is no surprise. So the diet, whether you are before sickness or during sickness or after sickness, should be somewhat the same because it's a healthy diet to take. Again, eating when you have it. Studies have examined many benefits of fruits and vegetables for the prevention of cancer as well as its impact on survival. But the interesting thing is that there's really no specific trial. These are clinical trials where they can actually evaluate the different fruit and vegetable-based diets with various levels of consumption for effect. Okay, so I'll translate that for you. What that means is that we really don't know how much of the foods to take. And if you take more of it, does that give you a better protection? We don't know that because the studies haven't got down to that level yet in order of sophistication. So I'm sorry for this terribly busy slide. There's a lot of words on it. But in the lab that we have, and that I'm associated with for the last number of years, that we are very interested in cancer patients' performance and their nutrition. Because we figure that physical performance and nutrition are linked. Okay? And so we know one of the linking mechanisms on being a healthy individual is to make sure that you have adequate protein intake. And the building blocks of proteins are amino acids. And the essential amino acids, branched chains amino acids, are extremely important for building muscle, especially after you've had some exercise. After exercise, branched chain amino acids are taken up and they build muscle faster. And that's importance here for exercise as well. So what we have done, we've created a trial here. It's a double-blind trial. Double-blind means we don't know which patient is getting the placebo. We don't know who is getting the branched chain amino acids. And guess what? Patients don't know that either. They don't know if they're getting a placebo or if they're getting the amino acids. So it's two-sided blindness here. So we don't know what's going on. Well, we know what's going on. But we don't know for sure what's happening. So we're giving these essential amino acids, and we're looking at physical performance, strength, and quality of life in patients with advanced cancer. And so it's a pilot study. Meaning that we haven't got hundreds of people in it. We have 40 people in it just to see how this is going to work. And the premise is that this supplementation has been known to increase skeletal muscle protein synthesis, which is important when you're losing weight, because in weight loss, you're losing fat and you're losing muscle. And of course, if you start losing muscle, then all of a sudden you start losing the ability to move around, to walk, to enjoy the things that you normally like enjoying. Picking up your children, picking up your grandchildren, or picking up anybody at that point in time. Okay? So that we've known in other studies that performance measures like a 6-minute walk test, how far can you walk in 6 minutes? Okay? And how hard can you squeeze a dynamometer? These are two outcome measures that can lead us into some very interesting predictions on what would happen to these people who suffer from lung cancer, because we've seen it happen in the frail elderly, and it works fairly well. So we are giving them this supplementation to see if they're going to improve their strength and to improve their functional performance. Okay? And so we're about halfway through at this point in time. I'm getting the nods. Halfway through at this point in time in terms of the trial. So this is something now that I'm just giving off to you because we wish to know, what are some of the interventions that we should do in order to make these cancer patients more effective individuals and have a better quality of life. second part of my presentation, since I was talking about the top 6 recommendations from the clinical individuals, now it's the top 10 research questions related to physical activity and cancer survivorship. Now, the top 10. This is a paper that came out, as a matter of fact, it was last week, from Kerry Cunea. And Dr. Chaput mentioned one of the Kerry Cunea's study back in 2003. Kerry Cunea is a colleague of mine. He's a senior research chair at the University of Alberta, and he calls himself an exercise oncologist. And I don't know if there's such a term, but he's coined it, and he seems to do pretty well because he's world-renowned in what he does. And so he published this very interesting paper in a rather obscure journal that had a very, very low impact factor. So I'm not sure what he's meaning to do here. But anyways, a lot of people are getting it, and a lot of people are reading it, so good for this journal. So he has gotten together some of the leading people across Canada and got them into the room and didn't let them go until they said, I want you to give me what your top 10 research questions are when it comes down to exercise and cancer survivorship. So he wanted to get an opinion from all of the experts. And so I'm going to give, the next slides are going to show you what these top 10 questions are. And they're kind of in order of priority in terms of the number 1 versus the number 10. Question number 1, does PA, that's physical activity, you're going to see PA a lot now. Does PA reduce the risk for cancer reoccurrence or improve survival? I think you'd agree with me that this is a brilliant question. You know, we can say that physical activity helps to reduce cancer reoccurrence and also helps to improve survival. That although, Dr. Perez might like his golden bullet, I think here we've got something that may not be in a golden bullet form, but it could be what I would call the exercise pill. Okay. We do know that higher physical activity levels after cancer diagnosis are associated with reduced overall mortality and cancer-specific mortality. So that we do know in some cancers that when these individuals follow an exercise program very religiously, okay, in terms of the time, in terms of the frequency, in terms of the duration, we find that in specific subsets of cancer patients that you can see up to a 30 to 40% risk reduction in breast cancer and colorectal cancer reoccurrence. This is a pretty significant finding. I know that these 2 cancers are the main cancers of study, but I can tell you that there are other studies coming out as I speak, looking at some of the other cancers to see if this is going to have a carryover in terms of eliminating the reoccurrence in individuals. So this is a very hot area in the exercise oncology field. Question number 2. Does physical activity influence cancer treatment decisions, completion rate, or responses? So now I'm going to be speaking to my oncology friends, to my palliative and supportive care friends, say that I know that oncologists take into account the overall health and physical conditioning of a patient before making treatment decisions. I know that for a fact because I've been with the team long enough to know that sometimes treatments are delayed until the patient can become a little bit more stronger. That doesn't necessarily mean that they have to lift more weight. That doesn't necessarily mean that they have to walk longer and further in 6 minutes. Sometimes they have to become stronger nutritionally so that before they start their chemotherapy and their radiation therapy, there's this very narrow window of time before from diagnosis to the time they start treatment. Sometimes that's a very short period of time. But as exercise scientists, we would take advantage of any time period to help the patient become a stronger individual so that they can take their chemotherapy and their radiation therapy, and to coin some of my colleagues, they'll become a better patient to treat, as opposed to a weaker patient to treat. So physical activity interventions after diagnosis can definitely influence treatment decisions if there is a time delay to manage specific symptoms. For instance, if you are suffering from cancer-related fatigue, will the fact of exercise started before treatment, will that help to improve the level of fatigue? Meaning reduce the level of fatigue. There are so many things that have to be done at this time. It's like if you want to coin the term prehabilitation before the treatment gets started. Or you can have prehabilitation before you need surgery. Okay? Okay? Dr. Franco Carli, who is a very renowned physician here, has done a lot of work in that particular area. And will be doing more work in that particular area because it's an excellent stream to follow. Just to show you just some of the data that's coming out. And all the data, by the way, that I'm showing you is probably less than 4 to 5 years old. And some of it was happening just last year, which tells you how fast this field of ours is turning over in terms of the information that's out there. Okay? The HELP trial, Healthy Exercise for Lymphoma trial. I love these acronyms. I tried to think for a long time, the HELP trial, and this is the START trial, and then there's one called the Challenge trial. I know these people who name their trials must think for weeks on how to rearrange all the words to get a word that means something for the trial. Healthy Exercise for Lymphoma trial. Okay, HELP. This looked at aerobic exercise, plus our usual care. And they found in 122 patients, divided up into 2 groups, the AE, the aerobic exercise trial, made up of 54 patients, they were receiving chemo, and the usual care, 68 of the 122, who did no activity, but received chemo. So here, this is a very simple design. Okay, and we just wanted to see what would come out of this. Behold, what you saw is that the aerobic exercise group, they were able to complete 94 of their chemotherapy cycles versus only 89% from the usual care group. Now, was that statistically significant? I'm sorry, I'm putting on my academic hat. Is this mathematically significant? Yes, it was. But to my clinician friends, they look at 94% versus 89%. You got me. Jordi's looking at it already. I can see he's not smiling at all. He's I'm glad, because I'm the same way. You know, we are so negative in our findings that we said we really have to see a substantial finding before we can actually say it works. But statistics are telling us it is working. Now we just have to see if treatments are telling us that it's going to work. And actually in the aerobic group, all 46% completed the response to chemo versus only 30.8% in the usual care group. So Kerry Cornea and his group back in 2009, they were very excited about these findings because they thought this was the first time that they actually saw something with respect to exercise training and how the chemotherapy can be affected by it. Next question. What is the physical activity prescription for cancer survivors? It's funny, about 15 years ago they used the term prescription for exercise and prescribing exercise. So the optimum PA prescription for cancer survivors is actually unknown. We try a lot of things, and some things work, and some things don't. Now, if physicians worked on that principle to give medications, that's not a very good premise to work on. I'll give you a medication and let's hope it works. And if it doesn't, too bad. So exercise is going to be treated the same way as the prescription, okay? So we don't know. So clearly this is an area where far more research is needed. Exercise programs must compare frequency. How many times a week do you exercise? The intensity. How intense do you work out? The type. You know, are you like this? Or are you like this? Or are you like that? Okay? And the time. How long are you exercising? Well, there is a trial that has started in Holland 2 years ago. They published their trial plan back in 2012. Now it's 3 years ago. And they're looking at a mixed group of cancer patients doing low-intensity exercise, which is somewhere about 40 to 50% of your maximum oxygen consumption, which is equivalent to probably a brisk walk for most of you, versus that of an exercise intensity between 75 and 80%, which will bring up the perspiration rate in most of you in this class. And so looking at these two rates of activity and intensities, we're seeing if you exercise at a more intense rate, do you have a better survival? Are you a better patient? We don't know this yet. Okay? Now, there's a lot of ifs with that. Okay? And I know that you're thinking of it right now. You say, I'm an advanced cancer patient, and they're going to make me exercise at 75% of my maximum? I'm not saying that. Okay? It's a mixed group. But clearly we have to select our people wisely, thinking of the safety involved. So in terms of research examining the type of exercise type, aerobic exercise, and you all know, I think, what aerobic exercise is. You've seen some of it on TV, you might even do it some versus resistance exercise. This is when you have a weight and you have to displace that weight over a certain range of motion. Okay? And we usually do these, kind of off days where we do an aerobic day one day, we might have a weight training day the next, and we kind of counterbalance that. So there's actually two major types. So here we had a 24-week program, males receiving radiotherapy for prostate cancer. And we found that in the AE and the RE, both improved in terms of fatigue after 12 weeks versus the usual care. Now this was big back in 2009 with Roanne Siegel, by the way, who was a physician at the University of Ottawa in medical school. She took all these individuals, all these males who had prostate cancer, divided them up into two groups who were suffering from severe fatigue, and found that her training program actually helped. But she extended the training program beyond 12 weeks. She went 24 weeks just to see, let's make sure that everybody is going to have the good impact of our routine. And lo and behold, they found after 24 weeks, only those males who continued on with their weight training maintained their low levels of fatigue. Okay? Whereas the others made no difference. Okay? So this tells you that there is some type of difference between the two modalities of exercise training. So that's why we separate them out and we have to judge them separately. We can't just group exercise all together and saying it's the same thing. It's not. Then looking at the time of exercise, the duration. Okay, and Cornea 2 years ago, of aerobic exercise in what we call a 3-arm trial, where you had frequency 3 times a week, intensity 55 to 75% of your peak, which is pretty intense, duration 25 to 30 minutes, or another duration that he was comparing, 50 to 60 minutes. So getting down to it, what was he saying here? He wanted to know, did you have to exercise longer to get a better effect? That was the simple question. And for all those people who say, I haven't got time to exercise, this is going to be a really great finding to all of you, because they found no difference between the two groups. Those that exercise for 25 to 30 minutes versus those who exercise from 50 to 60 minutes. No difference. Jordi, it didn't even come close to significance. Okay? Which means, clearly, because people are always finding out or trying to say, what is the minimum amount of work I can do for the maximum bang for my buck? Okay? And so we find that there is really no difference between that at all. Another question that came from the think tank. What is the role of sedentary behavior on cancer survivorship? Role of sedentary behavior. There's several papers that came out recently making a magnificent discovery saying the more sedentary we are, the more sick we're going to be. And that's the truth. And it sounds like back in 2014 that this was a remarkable finding. But I can tell you back in the early 50s, the British found this out very early because there was the double-decker bus. You know what a double-decker bus is? For those of you who've gone to London and you've gone in a double-decker bus. You have the double-decker bus driver. He was the sedentary guy in this study. And back in 1950 to 1953, I'm aging myself a little bit, but that's okay. Then they had the ticket taker on the double-decker bus. So all of you people remember the ticket taker. The ticket taker would be walking along the bus, have to go up the stairs, take the tickets, every stop, go back down, take the tickets on the ground floor, go up to the second floor. I tell you that this person, during the course of the day, got a tremendous workout. The bus driver, plantar flexion of the foot and brake. Foot plantar flexion and brake. So that was pretty much it. And so guess what the findings were? The findings were, longitudinally speaking, that the sedentary bus driver suffered more of the morbidity effects of sedentaryism as opposed to the ticket taker who kept on going up and down the stairs. Same environment, same bus, they worked the same amount of hours. It was such a great controlled experiment with such very interesting findings. So when somebody tells me today that a very interesting and novel study got published 2 weeks ago saying, guess what? The more sedentary we are, the more we're going to get sick. And I'm going to say, we knew about that back probably in the 1950s, but I don't want to burst any bubbles. So sedentary behavior, sitting and lying, is emerging as an important and distinct area of scientific inquiry. Clearly the sitting and laying time for the cancer patients, especially when you're in treatment, and fatigue, is clearly an issue. I'm not going to make light of that. Okay? And of course, the more sedentary you are, there's a stronger association with some of the carcinogenic mechanisms. Okay, so obesity, metabolic dysfunction, okay, inflammation. Inflammation's a big one. Okay, when it comes down to this. So when we look at the sedentary behavior in cancer, what are we talking about here? There was one study that was done just at the end of last year by Lowe and her group, patients with brain metastases. So they took a study. They had sitting in supine for 20.7 hours a day, standing for 2 hours a day. This was a group of individuals. That's all that they did. They found that patients greater than 20.7 hours reported higher depression rates, greater anxiety, more drowsiness, and interestingly speaking, they were better functioning individuals than the ones who had less than 20.7 hours. But the patients that stood, or just stood, I'm not talking about exercise as I've been describing it, but just stood more than 1.6 hours per day, had a better quality of life. So clearly this is the beginning of some type of research on sedentarism. And it's a really important area to think about, because all you people who get your kicks by going to your gym and working out for your hour, and you say, I've done what is recommended by the Canadian Health Association and by the US norms and everything, and you go back and you sit down and you watch TV and you sit around with your family, and then you go to bed and you wake up gearing to do your 1 hour again. So you do 1 hour out of 24 of activity. Nothing else in 23 hours. So are you really protecting yourself? Okay. It looks like the literature is saying you've got to do more than just your 1 hour. It doesn't have to be bouncing off the walls to music, but you have to be more active over the course of the day. So what are the most effective behaviors for change interventions for cancer survivors? This is kind of an interesting thing. And this is when I said for Tristan, if I can have Tristan in some of my pudding, I give him and my pudding to some of these people who are contemplating, I don't know, I haven't got enough time in the day to do exercise. I don't really feel all that motivated to do exercise. The fact that you have cancer, is that going to motivate you? That doesn't really motivate me either. And that's not surprising. Well, it's not surprising to me, because when we saw the heart failure patients and patients who had just had major cardiac surgery, triple bypass, and said, this must motivate you to do some exercise. I don't know if I'll have enough time. What, enough time? Enough time for what? Okay? So we got to find ways to really get these people involved. Less invasive interventions don't seem to work all that much. For instance, you get printed material with exercises on a piece of paper. Okay? You've gotten that before? Yeah. And I bet you know where it is. It's probably, oops, I got it put out into the garbage or in the recycling under the newspapers that you haven't read over the last 3 weeks either. So that's where it goes. Then you have the more invasive ones. That become more, it becomes better. Telephone contacting. We used to do that years and years ago with beepers, and the people who were involved in the study got so annoyed with us because they would be beeping all day long, and we'd be asking them, what are you doing? And take their beeper, and they'll say, I'll tell you what I'm doing with your beeper right now. And we were trying to get some idea about their activities. But then you have, supervised group or individual support. That's becoming very popular, but it's also very expensive. It's like having your own personal trainer follow you around the entire day to make sure that you're doing more than sitting for 20 hours and doing more than just standing for an hour and a half. All right. Then there's this whole thing about social networking, and I don't know much about that, but I know it's with emailing and all of those other things, with all these interventions that seem to be, that may work really well for the AYA group, the young adults, as they are always in touch with Facebook and Instagram, and I know all these terms because I've been told these terms. I have no idea what I'm really talking about. But anyways, this is where it seems to be neat. And I said, I'll meet you at the corner to do some walking. Now that's really cool to do. There's been studies just recently, Hatchett and all, are looking at emailing one another to get some type of thing going with your intervention. So it's changing. Which cancer variables are modified? Well, you've got the START trial and you've got the HELP trial. Chemo protocols affect physical activity, so that if we look at resistance training, there's an increase in strength in breast cancer patients receiving non-taxane-based chemo as opposed to taxane-based. So it looks like the type of chemotherapy that you get can actually affect the outcome of the physical activity that you do. Okay? Not many studies on that, but it's an interesting thought process to have, especially all my oncologists and the radiation oncologists and all of them. And in the HELP trial, looking again at aerobic activity on your lean body mass, that's pretty much your muscle mass within you, and that the aerobic group had significantly increased in their lean body mass, and these are stage 3 and stage 4 lymphoma patients. They had greater mass increases than stage 1 and stage 2 lymphoma patients. That may not be too surprising because they started from a lower base, and so they have a lot of catch-up to do, whereas the stage 1 and stage 2 had a slight increase, but not at the same magnitude as the sicker patients did. So there is a chance for them to at least show some significant increase. And clearly there are safety issues, very prominent safety issues. Several of the presentations tonight talked about reduction in your immune system, being immunosuppressant. When we exercise, especially when you exercise very strenuously, that can reduce your immune system. In a healthy population, we see sometimes athletes that work out really, really hard day in and day out. They're more susceptible to colds and flu, and their immune system is down. So we've got to be careful that we don't give that type of intensity to cancer patients, because many of them are already immunosuppressed. Low hemoglobin, low white blood cells, low platelets. And then you have to think about the advanced diseases, locally advanced and metastatic. We're still having discussions in our lab, what is going to be the best form of treatment in terms of physical activity for them. It has to be done on a very personalized basis. And the appropriate safety screening. What can we do to start eliminating barriers of people to join exercise groups? So when I say that 38% of recent experts expressed difficulty in answering all safety issues, because many of our experts really don't know all that much about physical activity. Okay? And the screening for it. Okay. Which specific cancer symptoms can be managed? Well, you've heard that exercise effects have been very positive for fatigue, for improving sleep disturbances, for depression, anxiety. Now, after reading, and there are hundreds of studies that have said this, but there hasn't been one study yet that took a group of individuals, for instance, who show a very high level of fatigue, all the groups of individuals, and then put them to an exercise program to see if that exercise program will reduce their level of fatigue. We find all these improvements in fatigue haphazardly, where we say, guess what, as a secondary outcome, so-and-so got better in terms of their fatigue scores. Oh, well, we weren't expecting that because we didn't want to measure it, but we got it anyway. But if you put it as the question, then all of a sudden you start getting some really sensitive issues. And then some of the more understudied symptoms, nausea and vomiting, pain, okay, that's overall pain, joint pain, neuropathy, appetite, constipation, and all those others. Okay? So is there a role for PA in advanced cancer patients? Yes, there is limited evidence, but unfortunately these studies have been so small scale, and the recruitment has been low and the attrition has been high. So, this is something that we still have to work on. More trials. What do we do to try to take the translation, try to take the information that we're doing in the laboratory and give it to the community to work? Well, we need to have more people involved, and we had to have less loss of efficacy in terms of the studies. So I got to compliment the CAMP support group in starting a program at a local YMCA for cancer patients only. Okay? It's just starting. And just like anything that's just starting, the flame is getting stronger. The flame is getting stronger. And the great thing is that as more people hear about it, we're hoping to at least take some of the information that we're learning in the laboratory and putting that translation into the community to see if it works. And so what I've done here, I've given you some idea of the call. I don't know if Andréane is still around here. She should be. Okay. So I think I've given her, I'm hoping that this is not your personal phone number, so that people can call you to see about getting involved. It's a program that's starting at the Westmount Y, and it's supported by CAN support from Cedars. And when I say it's supported, the class is free, and that you can go in there twice a week. Okay. So I'd like to acknowledge my my collaborators, Antonio and Domenico, and all the grad students that have helped me with this presentation today and helped me every day in terms of understanding this issue about cancer survivorship. And I would like to thank you for your attention and for having me go over time.
Okay, I'd like to thank all of the speakers. I learned a lot. I hope you all did too. So we're going to try and squeeze in a few question and answers. So if people have some questions they wrote on a note card, we're going to send some people around that can pick those up. And so the speakers... So maybe we can have the speakers come up here and we'll try and organize some of these questions. Okay, so we're going to start with some of these questions. I don't know if we'll get to all of them, but we'll try our best to get through as many as we can. And particularly ones that we think have a wide application. The first one here, I think is a question maybe a lot of people have. Should we change our eating habits to eat more organic, or is this a myth? So I think we know who this question's for.
What was the question again?
Should we change our eating habits to eat more organic, or is this a myth?
Well, when you say change your eating habits, I'm not a big fan, and I know that my clinical support staff would tell me that they aren't big fans of changing established eating habits for something else. And I think I mentioned something on one of my slides that things are going fine, and then trying to change your dietary habits, and then all of a sudden become a little bit more depressed and a little bit more tired because you're trying to start something new is not the best thing to do. But clearly, if you are lacking in some of the nutrients, all of these supplements are exactly that. They're supplements. They're added to whatever you're supposed to be eating. So I guess I would have to say that I would ask that you keep your regular dietary habits, or give a greater shot at keeping your dietary habits going as opposed to going to supplements. I wouldn't know.
Next question we have here is regarding flu vaccine. So if you get the flu vaccine while you're in chemo treatment, will this minimize the chemo results?
Is that loud enough? Yeah. So we're not sure about that, but however, what we do know is that if you are a cancer survivor, especially if you're 65 years of age or older, and that you don't get your flu shot, that you're at much greater risk of developing a respiratory infection if you do get the flu. So for those people that fall in that category, we need to do more prevention with regards to that, because the studies are showing from the CDI for 2009 that we're failing miserably because less than 30% are getting that flu shot. I'm going to do my best to translate the question. The question is, I think it's going to be for Dr. Gilmore. Is it possible to actually stop cancer, which means like apoptosis, basically, can you actually stop the cells from growing, the cancer cells from growing, and if so, what is the best way? Loaded.
This is through either diet or exercise? I assume so. Well, I can speak perhaps more to exercise and looking at the effects of apoptosis. And that's the programmed cell death. Because all of our cells has this program in it that our cells will die. Cancer cells, unfortunately, lose this apoptosis and they just seem to go on and on and on and on. That is the problem. In the very few studies that have been done, especially looking at the immune system and how the immune system can affect how the cell is programmed to die, we find that it does bring on the apoptotic events. We haven't checked this out in a group of cancer patients. We've checked it out in individuals who are susceptible to flu and to colds and that, but not in a cancer patient. So this would be a very interesting line of research in terms of how exercise can possibly affect the apoptotic cells. Now, when you're talking about any type of nutrition and nutritional intervention to influence apoptosis, I haven't read anything that would clearly indicate to change your diet and start to understand. It's probably more convincing in exercise, but it's really limited. So please understand what I'm saying. If there's a limited amount of evidence there, so I won't go out on a limb and say, yeah, go and exercise, and that's going to start killing off your cancer cells. Because that would be a very irresponsible thing to say and to try.
There's a question here which maybe some of you are interested in. Will tonight's presentations be available? And the answer is yes. So the presentations will be available on the web at the Goodman Cancer Center website. So if you look that up, you'll be able to find those there. So here's a question. It's fairly general, but I think it's actually an interesting question. How do you define fatigue? So perhaps there's people out there that maybe don't really know if they're fatigued or just a little bit tired.
I am fatigued right now. Does that count?
Well, fatigue has been an area of interest, personal area of interest of mine for a long, long time. And I'm not going to take the next half hour and to bore you with that, but when you think of fatigue, you think of muscle fatigue. So you think that the fatigue is just around the muscle area, but then you have to think of what is the organ in your body that is actually moving the muscle? It's the brain. The brain controls all of our muscle movements. So you have to start linking fatigue centrally to the brain. And when Dr. Chaput was talking about brain fog and people not working out well in terms of fatiguing symptoms, that I think for the cancer individual, I'm not going to eliminate the muscle as a source of fatigue, because it probably is. Because if you have less of it, then you're probably not going to be as strong as you should be. But the muscle that you have left may not be innervated well because the message is not coming from the brain to your muscle. So that there's a whole area of interest that can start to explain cancer-related fatigue in that particular way. We're neophytes when it comes down to starting to look at that, especially in the cancer population. Great question.
So there's a question here about prescribed treatment protocols, and maybe this could even be a little more general for palliative care and whatnot. So are the protocols at different sites standardized? So if a patient goes to one hospital or another, are they standardized, or are there different protocols that are existing at different sites?
No. I think there's protocols for chemotherapy, but I would say if we looked at protocols for pain treatment, it would vary quite a bit from site to site, depending a lot about what the strengths of the individual practitioners are. I think if you look at our hospital and our cancer rehab program, there's certain strengths. There may be, I know Dr. Vigano is looking at some of the protocols used worldwide in treating cancer cachexia. So they are trying to standardize not only the treatment, but really the measurements and the definitions. You asked, what is fatigue? Well, we have to try to standardize the definition of fatigue so we're all talking about the same thing. So I think there are certain protocols, especially for, in oncology for treatments, but in many of the supportive care areas, there are actually many centers that don't provide any of these services at all. So
it's more a question of innovation in these cases.
Borod, isn't the Rossi network trying to standardize the academic health network that was performance evaluation?
Well, yes, but they're very much at the embryo stage, and we're talking about standardizing throughout the course of treatment. So I think when we look at cancer treatment, the first thing we're looking at is really treating the cancer. You know, what chemotherapeutic regimes are available. And so we don't want to put the, now in terms of prehab, you know, these are areas that haven't been well defined. Will exercise and a good diet help patients go through their chemotherapy? These are the type of things that we're assessing, but there are not many programs throughout the Rossi network, so we're looking to link with different hospitals within the McGill University academic health network to work together in defining these different protocols.
And so this is just a follow. Is there an opinion on whether going to different centers for second opinions is something that's valuable, or is this something that...
I will say that I think that that's a very, very unique and personal question. I think that everybody goes through a journey of cancer differently, copes with it differently. I don't want to use the word accept because I don't think it's the word we should use. I don't know that anybody accepts cancer. I think some people come to terms with it or live with it because that's what the cards have been dealt. So I don't know that I would recommend whether or not people should be shopping around one way or another, but I think you should just try to get the proper care, and if you feel that you want to have a second opinion, well, by all means do so, but if you feel like what you're getting is the right deal, then just stick with it, because I think that's a very, very personal question, really.
The only thing I would add to that is everyone goes through their treatments in an individual way. Some patients want more treatment, some patients want more chemotherapy. They will always find a physician that may offer more treatment, even though perhaps more treatment isn't necessarily beneficial. So yes, I think people will search for second opinions if they're really not happy with the treatments that they're getting, although everyone pretty much goes to the same conferences and gets the same information and knows what agents are available. I think what I find sometimes the biggest concern is when patients go on the internet and then they go to different centers across North America looking for that magic bullet, and often at great expense and a lot of distress. So, you know, I know when people come to us in palliative care, they've often exhausted their various treatments and they're looking for this, and generally we counsel them not to go on a wild goose chase because there's a lot of individuals out there selling a lot of different types of treatments at great expense.
So I think in the interest of time, we're going to wrap that up. We've answered a number of questions. A few we didn't get to, but I think we have a few housekeeping things that we want to take care of at the end. So first, I'd like to thank again the speakers for coming in and answering questions. I'd like to thank the many volunteers that helped make all of this possible. I'd also like to thank you for all coming. So before you go, there's a couple things. I think we want to find out how people, you know, how the networking and how people are hearing about this. So I'm just going to ask for a show of hands for how you heard about this event. So how many people heard the speakers on the radio? Okay. And how many people saw an advertisement in the newspaper? Couple? Okay. How many heard, received something in email? Email seems to work. Heard from friends, family, word of mouth? Okay. Website or Facebook? Couple? From letters. Anybody still getting mail? Okay, so on your way out, there's a number of tables outside that you can stop by. There's tables for the Goodman Cancer Research Center. They're selling the Smart Palate Cookbook. Oh. So there's the cookbook, which we actually have a few here as gifts for each of the speakers. There's also tables for the Rossi Cancer Network, Can Support, Cedars Cancer Institute, Abbott Nutrition. So please stop by those and pick up some more information. You can pick up free parking vouchers at the registration desk. Okay, so you can get free parking here. Again, thank you for coming.